right, we are back in from the beautiful, warm day outside here, but the harmful rays of the sun. Listen, the month of May is the Cancer Awareness Month, and in honor of that, we have with us, we're joined by skin cancer doctor and plastic surgeon, Dr. Justin Piasecki, who is here. Welcome again, doctor. And I know you're from the kitchen to the frying pan, so to speak, here. So you created, or you're part of this this plastic micrographic surgery. Did I get that out right?
You did, yeah. Perfect.
And what is that exactly?
So, a little background first. So the most common types of skin cancer are basal cell carcinoma and squamous cell carcinoma. We'll get to some examples of those, but they most frequently will appear in sun-exposed areas, which are oftentimes is the face. The gold standard for treating those when they're on the face is a technique called Mohs micrographic surgery. It was named after the general surgeon who came up with the technique back in the 1930s. Most or the vast majority of the doctors worldwide who are certified, who have received the extra training, become certified in the Mohs technique, which carries a 99.2% cure rate for the cancer and is the most tissue-preserving approach to remove it, are dermatologists. And dermatology is a fantastic field. It's a medical subspecialty such that which means in very complicated scenarios where the cancer is very extensive on the eyelid or a great deal of the nose is missing, the gold standard would be to refer a patient to a plastic surgeon because the dermatologist hadn't received complex training in reconstructive surgery techniques, which meant more inconvenience for patients. Sometimes delays in treatment were a week or more, or sometimes even longer. So folks were walking around without half their nose or a big portion of their lip or their ear. And so I decided to train in both of those things. So it turns out I'm the only doctor on the planet who's certified in the Mohs technique, but also board certified in plastic surgery and facial plastic surgery. And the benefit is that folks can come in and we can offer them the highest cure rate. But because once we've removed a cancer, we've traded one problem for another, meaning we have a cancer, now we've traded for a big hole, it's really only half the job is done even when we've cured the cancer. So very much like if you take your car to the car shop with a flat tire and they say, we figured out your problem, it's a flat tire, and you say, great, I knew that, and they put you in the little room, you know, where they try to sell you the air filter, and you're sitting there like this, and they come and they ring you up and they say, we fixed it, we found your problem, fix it, it's gone, you're cured of the flat tire. And you say, great, and you walk outside and your wheel is off.
Well, we have some photos right here, Doctor. Can you explain to us what we're going to be looking at?
Sure, absolutely. So the picture, sorry about the graphic nature of this. These are some patients of mine. The picture of the gentleman on the left that you see is before reconstruction. And so the cancer actually began as a very small point on the rim of his nose. It really did not look like very much at all. And after applying the Mohs technique, that was the full extent of the cancer. That's just removing the cancer, but now he's cured of cancer, but arguably I've given him a larger problem than he had before. So then after reconstruction, one of the benefits of being the same person removing it as reconstructing it is I know exactly what I've removed and where I've removed it from, so such that when swelling starts to set in and scar contracture, there's that handoff loss of information where it can be very difficult to tell where the actual problem is and which aesthetic landmarks are involved.
There's also one with a patient of yours with an ear that you let's show that again. Graphic nature.
Sure. So far left is after excision. This is a squamous cell carcinoma. And that's my gloved finger extending through the defect. So some of these cancers will go full thickness through some facial features, which is problematic. And then on the right side after reconstruction. So we need to get in medicine and surgery, our goal is always to get people across the finish line from point A to point B. And my feeling was for patients with complex cancers, on their face, where the face is so important in interacting, not just in how we view ourselves, but interacting with society, that it's a functional concern to make it look normal again.
But to make it look normal, like it almost, you're not saying that you stuck your finger in the ear and then after you're done, 10 minutes or half an hour later, the ear looks like the ear.
Correct. That's a great point, yeah. So that's after they've healed. So the surgery occurs after we've removed the cancer, and then healing takes time.
Do you take it from a different part of the body?
It depends. Sometimes spare part surgery is sort of, we have to create something. There are two rules in reconstructive surgery. One is we cannot replace tissue that's missing, and the second is we can't cut through the skin without a scar. But if you go back to that first photo, the first gentleman, I don't know if we can put that back up, the goal is to make it look like we broke both those rules. So the tissue that is missing on the left has not been replaced on the right, but there's actually a component of a portion of the ear, a portion of the forehead, and all the scars and access incisions are hidden.
That's how you do it. So what are some of the warning signs that we should be looking for? As you see, you said it was a small, you know.
So the common types of skin cancer, basal cell carcinoma and squamous cell carcinoma, which by the way are more common than all other cancers combined, are typically not what a person would necessarily think would be associated with a cancer. Most folks would think common sense-wise, would there be this giant fungating mass coming out of the side of my head or something? And sometimes that actually, that can be the case, but in most cases, the early signs is a wound that won't heal, and we're showing now is a flat, pearly patch of skin where the hair follicles have been obliterated with some tiny blood vessels over the top. An area that bleeds with minimal trauma. So if you get out of the shower and you're toweling off and there's an area of the skin that starts to bleed a little bit, that's not normal. And/or a scar, something that looks like an irritated scar that's growing without any history of trauma there.
That could bear anywhere on your body, right? It doesn't necessarily have to be your face. You could have it on your back, on your arms, legs.
Absolutely, and anywhere. We think the predominant risk factor for developing these is cumulative sun exposure over a lifetime, predominantly in childhood. So, so certainly the face, head, neck, and hands are areas where we see these more commonly, but we can see them all over the body. So the key thing to look for is change. Change is the most sensitive indicator, something that you want to have investigated further.
When we come back, we're going to talk about our best line of defense right here on the other side of the break, and so much more to be educated on about what we're all subjected to, the sun. That's one point or another. Don't go away. We'll be right back.
Thank you.